Hello everyone, today's discussion is on the respiratory infections. So let's get started. So I want to provide a brief idea about the respiratory system and the anatomy part. It's divided into the upper respiratory tract and lower respiratory tract. So as you can see over here, the nasal cavity, the pharynx, and the larynx. These parts are included under the upper respiratory tract, which we call URT. And the pharynx is further divided into the nasopharynx, the oropharynx, which coincides with the mouth, and the laryngopharynx, which is just very close and adjacent to the larynx. And the larynx, as you know, is the voice box, which includes the glottis. And if you move down, the trachea is also called as the windpipe, and it has C-shaped cartilaginous rings so that it can prevent collapsing of the trachea. And there's like C-shaped so that the esophagus can house the food particles, and when the food particles move down the esophagus, it provides more area or accommodation for expansion. So that's why these rings are C-shaped, open at one end. And then as you move down, the trachea bifurcates over here into two primary bronchi or singular bronchus. This point is called the carina. It's having some cough receptors or reflexes in case anything moves into the respiratory tract, like food particles, then there would be a cough reflex because of those receptors over here. Anyway, so bronchi, then it branches further and ends up into alveoli, a group of grapes, like it looks like a bunch of grapes. The alveoli and the alveolar sac with the gas exchange actually happens. So the upper respiratory tract infections, they are infections of airway above the glottis or vocal cords. That means the infections typically involving the nasal region, the pharynx, and the topmost part of the larynx region. So tonsillitis, pharyngitis, laryngitis, sinusitis, and this includes the nasal cavities, and the otitis media, that is the middle ear infection, and rhinitis. And these are the typical symptoms associated with it. So rhinitis or common cold, and it's caused by these viruses, a group of viruses that especially affects kids. Sinusitis, agents of acute sinusitis are rhinoviruses and influenza viruses. And there are some bacterial agents as well which cause sinusitis, like kids especially have they have these paranasal sinuses getting blocked and serving as good breeding grounds for bacteria, and that's how they end up with bacterial infection, and they would need antibiotics to resolve those issues. So over here, this diagram shows the sphenoidal sinus, the ethmoid region, ethmoid bone, the frontal sinus, the maxillary sinus. So these are cavities, sinuses and cavities, and the mucus sometimes gets infected in these particular regions. Next, pharyngitis and tonsillitis. So as you know, like tonsils are, they belong to the lymphatic system. They contain they are the nodules that contain the WBC and cells of the immune system, and they provide innate immunity. So it's a natural defense against pathogens. And as you can see over here, the region where peritonsillar abscesses collect, so this particular one is inflamed, and there is active work going on over here, like the pathogen is being tackled by the WBC, and it also shows over here some abscess formation. pharyngitis and tonsillitis. These are very common cases that happens in case of viral upper respiratory tract infections. And laryngitis, that's caused by these viruses, and it results in hoarseness of voice, especially because the larynx is the voice box. So there's hoarseness of voice because the vocal cords are like inflamed, and lowering and deepening of the voice. Next, the laryngotracheobronchitis, and kids especially less than 3 years, they show croup, and croup is like a barking hoarse cough, and it sounds like barking, and kids especially have inspiratory stridor, and stridor is like the whistling sound between breaths that can be heard in case of kids when they're asleep. Next is epiglottis. So what is epiglottis? Epiglottis is typically the leaf-like structure that hangs on top of the larynx, and it's like a protective valve. It prevents the food particles from entering into the respiratory tract. So sometimes it gets infected, and there is swelling, edema, and inflammation, and especially this particular influenza type B affects the epiglottis. So if you look at this picture, here is the vocal cords in closed position, they're closed, and over here the vocal cords are in open position. So these are the cartilages of the larynx, like the cuneiform and the corniculate cartilages, and the true vocal cords would be attached to these cartilages. So these are the true vocal cords, these ones. And then there are false one as well, the false vestibular fold, false vocal cords. The true vocal cords actually, they vibrate, the false do not. And the false do not produce any sound, just maybe a deep hoarse sound. And here's the glottis, and this space is called as the rima glottis, and the epiglottis is this one, and it hangs on top of the glottis and the vocal cords. That's the epiglottis, and when it gets infected, it gets inflamed. The lower respiratory tract infection, most often it is pneumonia, and either it is community acquired or it is hospital acquired. So first of all, the community acquired pneumonia, and that is called CAP, and streptococcus pneumonia, that's the usual culprit, and these are the pathogens, especially the RSV, influenza, they cause the community acquired pneumonia. And this is the CURB, C-U-R-B score. It's a 5-point scale, and it typically provides information about a patient's condition, like taking into account his blood urea nitrogen, about any delirium or confusion, respiratory rate, blood pressure, and the age. Higher the score, greater is the mortality. So this CURB score provides information about a patient, whether he should be hospitalized or treated at home. Hospital-acquired pneumonia, HAP, that is also called the nosocomial infection, and especially either it is ventilator-associated or clinical pulmonary infection. So the CPIS and the VAP, they provide information about the status of a person who has acquired it, the pneumonia, from the hospital. Sometimes after the surgery, they show signs of infection, maybe because the surgical equipment was not sterilized well enough. So here's some information and data about the clinical pulmonary status of a situation, and ARDS, that is acute respiratory disease syndrome. Causative organisms, well, this is gram-negative bacilli. It is most common, and Staphylococcus aureus. This is a very dangerous bacteria, and it is both methicillin resistant and also methicillin sensitive. So sometimes it is resistant to particular antibiotic methicillin. Sometimes it is sensitive, and people usually get this after a surgery. Maybe there is some kind of a pus. There is some kind of a pus or infection or abscess seen, and the surgical incision, it did not heal well, and it resulted in infection just by staphylococcus. Lobar pneumonia, well, the bronchi, they branch into primary and secondary and tertiary. The lung has lobes, around 3 lobes on the right side. Over here, if you look at the anatomical features, this is the right lung. It has 3 lobes, superior, middle, and inferior, and the left one has 2, and they're separated by these fissures. So the lobar, when the bronchi bifurcates at the carina and enters into the lung, right here, this is the lobar or the secondary bronchus. And why there are 3 on this side and 2 on this side anatomically? Because this is called as the cardiac notch, because it's housed by the heart over here. So the lobar bronchus is right here, and then it bifurcates, it branches further into a segmental or tertiary bronchus. So we look at this picture. It shows you typically the primary bronchus that branches further into secondary or lobar, tertiary, and then smaller bronchi, and then bronchioles. Interstitial pneumonia. This is an X-ray image about interstitial pneumonia. So typically the alveolar cells inside the lung, here it shows anatomically the alveolus, and it shows the capillary blood vessel or the endothelial wall of the blood vessel in contact with the alveolus. And the alveolar cells have a type 2 surfactant secreting cell. So the purpose of this surfactant is to prevent surface tension. So it keeps these alveoli or alveolar cells inflated so that they do not collapse. So that is the purpose of this. It's a lipid kind of a component that is secreted by the alveoli. And the alveoli are filled with air, gas, and these are the red blood cells in the capillaries. And well, here is where the gas exchange takes place. So oxygen is given into the capillaries, and carbon dioxide is picked up. And it shows you here the fused basement membrane of the alveolar epithelium and the capillary endothelium. Bronchitis, that's the inflammation of the bronchus, which occurs either as an extension of upper respiratory, such as influenza, or may be caused directly by bacterial agents. And here are the common symptoms. So if it is caused by bacteria, these are the examples. If it is viral, these are the examples. Bronchiolitis, that's the inflammation of the very small, tiny airways or bronchioles, and it presents as an acute viral infection that primarily occurs in children less than 2 years. Bronchiolitis, and it is caused by these viruses. Then there is atelectasis, that is pressure on the lungs that causes them to collapse. So this is also another situation. So the pressure inside the lungs is called the intrapulmonary pressure, and the pressure that is present in the walls of the lungs, this is called intrapleural pressure. So the wall has the visceral pleura, and on top of it there is a parietal pleura, and in between there is the parietal cavity, which has the pleural, it is the pleural space. Okay, so what happens is sometimes because of any infection or inflammation, or maybe due to some kind of an accident, this wall, it ruptures, and pressure on the lungs causes them to collapse, and that is when it is called atelectasis. And air enters the pleura. It may enter from the lung, may enter from outside, and the loss of negative pressure between the pleura. So the pressure that is typically there in this intrapleural region is negative, and that negative pressure is lost. So this is how healthy human lung looks, and this is how the tobacco or the smoker's lung looks, and it's more prone to infection, especially if a person is smoking. It would really damage the lung. So elasticity of the lung. So the lung compliance refers to the measure of elasticity of the lung, and it decreases with age, and especially in emphysema, COPD, or fibrosis. Fibrosis means there would be formation of clots in the lungs, so the lung compliance would reduce. How well the lungs can recoil and maintain the elasticity so that it can, inflate and deflate when the diaphragm stretches, and the external intercostal muscles will they will contract and stretch and pull the lung to increase the volume. And if the lung has become more rigid and it has lost the elasticity, then it's a very painful breathing. So COPD, that's chronic obstructive pulmonary disease, and it's a difficulty in expiring the air due to damage to the lung tissue or overinflated lungs, and there will be buildup of mucus because people are not able to exhale out, and the recoiling capacity of the lung is diminished, and loss of respiratory membrane. Air can get in but difficult to expire out. And typically you should know that inspiration is an active process, whereas expiration is passive. So during inspiration there is an active process of diaphragm and external intercostal muscles, stretching and pulling and expanding the thoracic cavity. Expiration is more like recoiling back. So when it is more passive, there's a chance that air gets in easily, but air can't get out easily, and that's when mucus starts accumulating. So asthma, the problem lies within the bronchiole, and bronchial constriction is due to smooth muscle contraction, and it can be caused by emotions, sports, or pollution. And people who take medicines for hypertension, basically beta blockers, they kind of constrict the smooth muscle contraction, and that causes kind of breathing distress for people. So eupnea, that's normal breathing rate, and tachypnea is faster rate of breathing. Bradypnea is like slower rate of breathing. Dyspnea is difficulty in breathing, and it could be because of respiratory distress, or maybe some viral infection or bacterial infection. So if you want to do the laboratory lab diagnosis for URTI, throat swab, or nasopharyngeal aspirate. For lower respiratory, sputum, induced sputum, tracheal aspirate. So these are some of the methods. Microscopy, these techniques are used for microscopy. And here is a table showing the neutrophils and pus cells, and based on that the score is calculated over here. Culture, so if when the culture is done, blood agar or chocolate agar, the specific details are mentioned over here. So here it shows the picture of Streptococcus pneumonia, carom coin appearance, how it looks. Then Mycobacterium tuberculosis, colonies of Candida species. So some examples I've provided over here. Fried egg colonies of Mycoplasma species over here. And lastly, the treatment. So community acquired pneumonia, empiric regimen is determined by presence of comorbidity and prediction of prognosis using the 5-point scale system of scoring. And these are the antibiotics that are administered in case of the bacterial condition, if they're resistant to a specific antibiotic. So the strain is determined, and then based on that the antibiotics are administered. So this is just a brief overview of respiratory infections. I talked about the anatomical features and the viruses and bacterial conditions that can infect a person, and what is the pathological implication, the symptoms, the treatment policies, and how it could be mitigated. Thank you very much.